All right. Start off with this one. I thought it was a cool case. Let me just make sure I'm showing the right. Okay, so.
Oh, sorry.
Yeah, so this is the case I was reading last week with one of our residents, and it's a right-sided lung transplant. You can see there's fibrosis here on the left side. Transplant's on the right, and I was kind of looking at this, and I didn't make much of this until the resident told me that it's new. So I thought that was weird. I thought initially that was just some bleb or some paraseptal emphysema, and thought it was something chronic. But she told me it was new since the last scan from like a few months ago. And so you look up here, there's really subtle, but there's some interstitial emphysema, very subtle. When you look at the prior, that finding's not there, but you can see this interstitial emphysema there. I was wondering what went wrong. And then in the setting of a lung transplant, one thing that when you see these lightning bolts, we talk about Macklin effect. This person wasn't intubated. So in the setting of a lung transplant, one thing that can happen is you can get some leaks with the dehiscent site. So this patient had this was like a week or two post-op, and it resolved on its own. So it might have just been a leak rather than a dehiscence, but you can see it right there. So it's kind of just overlooked on the prior study. But yeah, interstitial emphysema in the setting of a transplant.
And it's self-resolved?
Self-resolved, yeah, because they didn't do anything, and this is all we have now. So this air kind of got trapped up there. I don't see this right there anymore. So now we're about 2 months after transplant, and I don't see that leak there anymore. And so I think we're just left with this.
It's cool. You know, it's interesting with these transplants. I never could understand it. Like, I saw a case recently of a patient that they have like these chronic pleural problems after transplant. And I can't figure out where it's coming from. Like, why do they keep having recurrent effusions? Why do they keep having persistent pneumothoraces? I mean, I don't know.
By the way, do you guys think of anything of this fibrotic? This is also another kind of interesting part of this case, this fibrosis pattern. Does that seem?
Can you feel the bases?
What's that?
Go down to the bottom. Yeah, it smells of connective tissue disease.
Yeah. I mean, it actually is a mystery, because I was looking through the chart on this guy, and he has a history. Initially, he was diagnosed with hard metal disease, lung disease, because he has a history of grinding cadmium in the 90s. And then apparently he gives a story that in the 90s he had a transbronchial biopsy at some outside hospital, which he couldn't remember the name of, so we don't have the records, but apparently they found the biopsy was for hard metal disease. But when the lung was transplanted, this wasn't giant cell interstitial pneumonitis, so the biopsy said it was inconsistent with that. It was just kind of airway fibrosis, but not really. I mean, could be from connective tissue, but he wasn't positive for anything. So just kind of a mystery. And then the other case that I have is this one. This one is very quick. So this is just an incidental, and I think this was just some kind of cancer workup, but just an incidental finding right there. This really subtle membrane spanning across the left atrium. So it's a core triatriatum. Just a nice example.
That's
incidental.
A more subtle one.
Yeah. Yeah,
I
very
think
subtle. It probably has some membrane or some fenestration somewhere, I'm assuming.
I think Seth showed I think it was Seth, maybe somebody did, showed one recently that had like it was like a partial, incomplete membrane that
Yeah,
was hanging out there.
yeah. If it's complete, I don't think they can survive really much.
Right, but it
That
wasn't
just looks
gonna,
like a web
yeah.
more
Yeah,
than anything else.
yeah, yeah. So like thin web.
All right, thanks for sharing
That's
those.
all I got.
All right, Travis, you got any?
Yeah.
All right.
All right. So this case is several years old, and it's not one from here, but it was one that made its way here. This is a patient that presented with chest pain, and we've all seen this many times. But this patient was transferred from a community hospital somewhere else with a diagnosis of type A dissection based on this CT. This was called type A dissection. The patient actually went to the OR and was opened up, which unfortunately does happen on occasion, but should never happen in a setting like this. This is clearly pulsation, and you can see how it parallels the wall. You've got similar motion of the pulmonary artery and ghosting of the SVC and the everything else, a little bit of the pulmonary artery as well. I always say too that when in doubt, a normal caliber aorta, and this thing's like 3 centimeters, rarely should dissect. Obviously, we don't gate here. Most of our scanners are fast enough now that hopefully this is not an issue. You could always gate, but I think it's important for any residents seeing this here. This is to call this is really indefensible, I think, in this era. And really, it's partly on the surgeon too, but they should recognize this or at least get a consult. But this one, they went in and recognized that the aorta was normal, and then I think they realized once they were in there that nothing needed to be done. So I was updating my aorta talk recently and came across this case from a few years ago from a site that will not be named. All right, this is one, just came in a couple weeks ago, and I had just given the residents my talk on pulmonary emboli and smoke. And so this patient came into the ED, and you can see in the lower lobes that you have, let me zoom in here a little, maybe change the window. See if we can get a better window low. Yeah, so right here, initial suspicion, there may be some PE right here, but notice that it's a nice straight level. Contrast is denser than blood. There's no contrast downstream or very little. The patient has reduced output. They have heart failure, reduced left ventricular ejection fraction. And so this is just layering contrast right here more proximally. And then the argument can be made, well, yeah, but how do you know there's not PE more distally? And I think that's a fair argument. In some cases, you may just have to say it's non-diagnostic. It's important not to call this PE, but I think here's another good example right there, recognizing that it's just really, it's not a diagnostic study. But as we do here and as many places do, this patient happened to get an abdomen and pelvis CT at the exact, well, not the exact same time, but right after it, which conveniently then gives you the venous phase. And you can see that these vessels do fill in. It's a little noisy, but it's just a nice reminder, of slow flow and smoke. And actually the patient, you can see they have pretty bad aortic stenosis, it looks like. And getting a delay can help in cases like this. All right, here is one that this is from a couple of years ago that came in here, but this is the first time I had seen it. And this is a patient who presented with altered mental status, and you can see has a hemorrhagic stroke. They had a subsequent MRI that showed multiple defects, and the patient had had a history of fever, intermittent fevers, respiratory symptoms. What's really interesting about this case is that the pertinent history was withheld or was not discovered until a couple of days after they had made it here. But they underwent a non-contrast CT, And, you know, right here along, so the esophagus is midline, and there's a strange little bubble of gas right there next to the inferior pulmonary vein on the left, in proximity to the esophagus, and not clear exactly where this is, but certainly extraluminal from the esophagus. And so, of course, this patient had an ablation about a month prior, but they didn't know it at the time. And I'm not exactly sure who figured it out or at what point, but reading the infectious disease note that was done around the time of this CT, you know, they were talking about Rocky Mountain spotted fever and all this other stuff. But then finally somebody pieced it together. They did a contrast enhanced CT the next day. And now you can see that, first of all, there's more air in the left, well, there's air kind of contained in the left atrium near that pulmonary vein, and a little bit of low attenuation. So big thrombus containing foci of air in it. And so this was an atrio-esophageal fistula, and unfortunately, as is the case in many of these patients, that this patient did not survive. But it was the first time I'd actually encountered it where it was a diagnostic dilemma just because of the fact that nobody recognized that the patient had actually had an ablation. So, but you know, this is clearly not just free floating air. This is associated with this thrombus and vegetation that's arising from that pulmonary vein at the site of the prior ablation.
Wow.
All right, and then this one, so this is a true story of showing the residents, giving them some cases, and I figured I would just show them some crazy stuff. And so this is a case that was seen during my residency, and this was like on a Tuesday I showed them this. And you can see there's a bunch of dense stuff pooling in the right ventricle and kind of scattered throughout the periphery of the lungs in a lower lung distribution, a couple dots and dashes there. And this was a patient who had injected elemental mercury. And so, you know, I don't think there's really anything else that looks like this. The mercury will pool in the RV and then end up in the pulmonary arteries. And I had a companion case. This is another one, and you know, zooming in, you can see not as much, but still little speckles of mercury. And I preface this with like, well, you may never see this again, but if you do, then you'll know what it looks like and know that there's really no diff. And I'm not making this up. This was less than 48 hours later that this patient came to our hospital. And I haven't seen this in 15 years, and I showed this to them. And then, you know, 2 days later, less than 2 days later, the residents got to see this case. And this one is a bizarre one, though. Now, this lady actually was transferred in with a diagnosis of mercury toxicity. And I can pull up the note, and then I can go through the CT and stuff. So mercury poisoning reported level, whatever 500 micrograms means. Obviously it should be 0. Her rheumatologist collected heavy metal serums recently and found this to be elevated. She had abdominal pain, sacral pain, joint pain, headaches, blurry vision, as you can see. And it seems like this had recently started. And unfortunately, we don't have any of the outside images, but they do say, you know, apparently she had imaging 6 months ago in her chest. There was nothing there. And then a month ago, these deposits had occurred or had been present. And so and nobody knows exactly what happened, but the thought is that she must have injected through her port. Now, the report on the outside radiograph was that there was, you know, mercury in the port, and I think, you know, this is mostly just the Huber needle here. I don't really think there's anything, you know, I can see in the port unless the tip is just too dense. But you can see similar stuff here as that other case, just tiny little super dense particles, some of it pooling in the right ventricle, as you'll see. I don't know exactly why they did a CT, but they did. And yeah, in her case, it's peripheral, well, scattered throughout vessels everywhere. And you can see some of it in the RV, a little bit of it pooled along the wall of the RV, and even along, it looks like probably in the coronary sinus there, or just in the right atrium. But you know, she didn't confess to injecting it, And the other peculiar thing is that some of it clearly ended up in her pelvis. And I guess these are in parapelvic veins. You know, I don't know, but that was the only weird thing about this. But it had occurred in the last couple of months, and presumably she accessed, reported, and injected, but we don't have a better explanation. You know, oftentimes, I think the other cases I've seen were attempts at suicide, but I don't know if anybody else has seen one of these, or wants to comment.
No, and I have no idea why they would do it. Not a very effective way to,
Yeah,
yeah, injure yourself.
yeah. I wish David and Howard were on here, because I guess when thermometers were made of mercury rather than alcohol, this used to be much more common. I don't know what much more means, relatively speaking, but again, there's not really anything else that I can think of that looks like this.
No, and I bet it's pretty hard to get elemental mercury anymore because unless you have an old
Right.
thermometer lying around.
Yeah, like thermometers, light bulbs. I don't even know where else you can find it. So,
Yeah, but enough to like
but
have it in liquid form to inject.
yeah, yeah, exactly. So,
Wow, that's impressive.
yeah, so that was the exciting case, and one of my colleagues was shocked that the residents knew what it was,
You
and it
can
just
now?
happened to be because they had just seen it. So, all right, that's it for these cases, for my cases.
I got a few I can show. Speaking of seeing things right after we talked about them, let me see here. No, wrong app. Let's try this again. All righty. You should see, we'll start with this case. So this is something I've never seen, and I'd be curious if Peter or Travis and everything. So this guy is in his, I think he's in his 50s now. He was living in New York in 2001 when the World Trade Center attacks happened, and was like blocks away and wasn't injured or anything, but he did spend the first 24 hours with like kind of rescuing and helping people around there. And ever since then, he reported shortness of breath. And we came across him because over the years he eventually relocated to the Midwest. This was his radiograph. It looks normal. He did have a CT scan, and this abnormality is not one that I dug around the literature, and people talked about asthma, sarcoid, and all sorts of fibrosis, and of course many of these develop years later. He was seen in a clinic in New York shortly afterward, did have some pulmonary rehab. He's a never smoker, and he does have a little bit of, I don't know if there's a little emphysema up there or just localized air trapping, but he has what looks like respiratory bronchiolitis. He's got these tiny, very hard to see, smudgy central lobular ground glass nodules in the same distribution that you would see. You can see them in here and there with RB. And then if you go down the bases, they're really kind of gone. And no other exposures. He does like office work or something like that. So doesn't live with a smoker, never lived with a smoker. His PFTs are sort of, they're in the normal range, so he doesn't not surprised given his thing. But have you guys seen any sort of RB from just massive dust exposure?
I haven't seen it, but I
No,
read it. You can get it. You don't have to get RB from smoking, right?
Right.
Is there other?
Well, like the majority of cases, I mean, like the overwhelming.
Yeah, the vast majority.
right.
Yeah.
It has been reported in people exposed to lots of diesel exhaust because there are a lot of particulates in it. So I'm guessing he just got a whopping dose. And of course, that dust was in the air for a while, that he just kind of probably got a bunch of particulates. And, I mean, there was asbestos, metals, concrete, and, things that burn. So that he probably inhaled stuff. But yeah, the stuff I read about is mostly like airways disease and asthma and sarcoid.
Yeah, I mean, it makes sense, but I have not seen that
Yeah,
before.
this is the only case I've ever seen of so-called World Trade Center lung disease, which is probably just a catch-all term for massive inhalational injury. But I guess with enough concentration, you can't clear it all. So that was that one. I mean, I don't know why he's still coughing, but it's been what 20 something years now, 22 years almost. Okay, this one is kind of cool because I don't have the path images, but it was cool because we actually have the path core. I did get to see them. So this is a lung transplant patient that presented with worsening function and cough and has was a double lung. And you can see as we go down to the lower lobes, we start seeing a lot of thickening around the bronchi. You see wall thickening, little bronchial dilation. And as I go down, you'll see more and more abnormalities. And then it gets quite striking posteriorly, that quite a bit of bronchial wall thickening. You can see out here, you get that appearance. So some mild bronchial dilation, bronchial wall thickening, and it gets pretty extensive. And then there's some small nodules. So they did, this looks like an infection. It does not look like rejection. So they did a bronch and BAL and transbronchial biopsies. And they actually got an acute bronchiolitis with CMV inclusions that in the airway epithelium, which is what our pathologist got very excited about. He had this one slide where it just showed one little inclusion, what the owl's eyes or something, in the actual epithelium of the lung, which is consistent with CMV. And of course, the titers were positive. But a lot of times when I see CMV, I don't see much in the lungs, or it's just it's little tiny nodules. But this one has striking airway involvement. So this is a CMV sort of bronchitis, bronchiolitis. And the patient did better with appropriate therapy. Then this last case is kind of crazy. So I think it was Maya last week showed a case of hydatid disease. And I got this case later that afternoon from elsewhere. And this is a 13-year-old who had a chronic cough and so I don't have the radiograph, but it showed a bunch of masses, and they were worried about TB. But you'll see this is now the worst case of hydatid disease I've ever seen. These are all hydatid cysts, just replacing much of the lung. And this one has all these fluids in it, and presenting calcium. So this one's probably ruptured or got super infected at some point. I'll make a corona quickly just to show. Yeah. I mean, I've seen the worst one I think I showed one a while ago that had like 4 big hydatid cysts, but I've never seen like this. I don't know the natural history of this, but I suspect they'll collapse with therapy, and hopefully he'll have some normal lung parenchyma behind. I mean, he's walking around being a normal kid otherwise. So, but you can see it's just huge concentration of cysts. And the same thing, what I've noticed with all the other cases I've seen is that they don't have liver involvement. They go down pretty low on the scan, almost through the whole liver. And I'm talking to one of my abdominal colleagues who's seen a bunch of liver cases. He said he doesn't see it in the lungs, and it was clearly reported. I know we've seen at least one with liver and lung involvement, but I think if you have with enough of these, it starts looking like it's either lung or not both. So horrible hydatid.
You wonder, right, if this is just hematogenous dissemination into the lungs. And I have seen one where I felt like it was transdiaphragmatic and pleural spread, but you're right. Oftentimes you'll see one without the other, either liver or lung.
Right. And I've never seen it. I mean, my experience is more limited than your endemic areas, but I've never seen it rupture into the pleural space, and I've never seen it invade anything. It just kind of takes up space.
Yeah, the most recent case I saw from a couple of years ago was like one huge cyst that ruptured into the lung because the patient came in with acute hemoptysis and other symptoms, and on the CT there was just a bunch of surrounding inflammation and consolidation.
Yeah.
But yeah, wow.
Yeah, pretty crazy. Okay, well, we're going to end early today because Howard and David and everyone else are out. But thanks for sharing, guys. And I'm going to be out next week, so I will not be on the webinar, but I'll be back the following week.
Thanks.
Bye.
Thanks, guys.